First of all, I would like to thank Dr. Malik and Dr. Brech for giving the opportunity to address this August occasion. I'll be very crisp, quick, as Dr. Mumina said, because the time is less and I'm the last speaker of the day. So I'll be talking about a paradigm shift that we're seeing in patients of idiopathic intraocular hypertension. So, what I'll be trying to convey today is the mechanism behind the development of intracranial hypertension in patients who have got transverse sinus stenosis, and how do we identify these patients, and once we have stented them, what are the safety profiles and outcomes. So, our objective is to obviously to understand the pathophysiology of intracranial hypertension and define it. The main purpose of today's talk is to understand the role of venous sinus stenosis in the pathophysiology of idiopathic intracranial hypertension, a brief description of the procedure, and how to identify the ideal candidate. And obviously, we'll be overviewing a few studies of comparison regarding safety and efficacy. So, as we are all familiar with idiopathic intraocular hypertension, our understanding is evolving day by day. And it was first coined in 1893 with the term known as meningitis serosa in patients who had headache, blurring of vision, and vomiting. And then subsequently, the term of pseudotumor cerebri, it came into the literature. And then in 1955, Foley's defined it as benign intraocular hypertension. But we all know that it's not benign because these patients, they have papilledema, and eventually they developed optic atrophy. So it's not something which is benign. So therefore, in 2011, a new term was defined, which was idiopathic intraocular hypertension, in which the CSF analysis was normal, CSF pressure was raised, and there was no mass effect or venous sinus thrombosis. But what we believe now, as we have more understanding of the disease, that it's not basically idiopathic, because we have found that more than 90% of the patients, they have an underlying venous sinus stenosis. So is this a primary etiology, or it's an effect of venous sinus stenosis? This we'll see in the subsequent slides. So as we all know, the basic management of intracranial hypertension is first line is medical management, weight loss, drugs that we are all familiar with, acetazolamide and topiramate. The surgical intervention comes as part of refractory patients. And in our setup, most of the patients who have refractory intracranial hypertension, they usually go up shunt. You end up having a ventriculoperitoneal shunt or lumboperitoneal shunt. So these are CSF flow diversion procedures. And in few selected cases and in few institutions, they're offering optic nerve fenestration. So basically, what's the link between a venous sinus stenosis and idiopathic intracranial hypertension? It's the same as the chicken and egg phenomena. Is it the primary stenosis which is causing intracranial hypertension, or it's the intracranial hypertension which is causing compression of the venous sinuses, leading to a false impression of stenosis, where actually it's not a stenosis, it is the compressible part of the venous sinus, which because of external pressure becomes stenosed. And I would like to explain this phenomena by this Starling resistor mechanism, in which if we consider that this is the venous sinus, so there is the hard part and a softer part, and this is the external pressure which is exerted by the intracranial pressure. So there is a pressure upstream and there's a pressure downstream, and the flow is basically determined by the pressure gradient between the up and between the higher and the lower value. So as the external pressure increases, there is compression on the venous sinuses. The lumen, it decreases, the flow increases, and what it does is that in order to ensure adequate flow through this narrow part, the upstream pressure increases, and a gradient develops between the initial and the second part of the sinus. And what happens at the end is known as the waterfall effect, that the more the pressure gradient, it has got no effect on the downstream flow of the CSF, and the pressure, it keeps on decreasing. The gradient keeps on increasing and the flow keeps on decreasing at a constant rate. So this is known as a positive feedback. So what we do in venous sinus stenting is that we mitigate the effect of external pressure on the venous sinus and we put a stent across this place so that we take away the effect of gradient, which is causing an upstream pressure and decreased absorption of CSF, which is behind the basic pathophysiology of intracranial hypertension. So how do we determine who is the ideal candidate? Obviously, the one who has failed medical therapy. And once we do a CT venography or MR venography, there has to be significant stenosis of more than 50%. I would like to add here that most of our radiologists, even if there is stenosis of the MRV, they usually end up labeling it as normal. So we have to see this MRV ourselves as neurologists because we know the clinical background of asking for that MRV. Most of our radiologists are tuned to report sinus thrombosis. So if there's no sinus thrombosis, so they usually label the sinus as hypoplastic or normal. So what do we have in, what are the areas that we should be looking for? It's either the posterior part of superior sagittal sinus or a junction of transverse and sigmoid sinus. It could be bilateral, it could be unilateral transverse sigmoid stenosis with contralateral hypoplastic transverse and sigmoid sinus, which is the usual pattern that we see in these patients. And obviously, we need to have a measurable gradient of more than 4 millimeter of mercury. I'll show you later how we measure this gradient. And obviously, the tetrad of symptoms, it has to fulfill to be labeled as idiopathic intracranial hypertension. What are the contraindications? Obviously, if there's thrombosis, you cannot find a definite stenosis, and there are other causes of intracranial hypertension. So what does this evidence show as compared to venous sinus stenting and CSF flow diversion procedures? 80% of the patients, they have improvement or resolution of headaches. And interestingly, 90% of the patients, there is resolution of papilledema and stabilization or improvement of vision over time. Pulsatile tinnitus immediately improves post-procedure. We have seen the moment we deploy the stent, immediately the patient tells us that tinnitus is no more audible. And obviously, eventually what it does in long term, it reduces the intracranial pressure and mitigates the effects of increased inner pressure on the body. So, which is more superior, stenting or VP shunting or traditional shunting? The mechanism is altogether different in terms of treatment. In stenting, we are decreasing the gradient, whereas in CSF flow diversion, we're just reducing the volume and diverting the flow of CSF. The complication rates, the revision rates, and failure rates are much more in CSF shunt procedures, and they can be as high as 50%. And obviously, the improvement in headache and vision are also variable or good as compared to excellent outcomes in patients with venous sinus stenting. So this was a recent study which has been published about a month back and in the Neuroendovascular Journal, and it was published in British Medical Journal as well. And it's, I think, to date, the highest cohort of patients of intracranial hypertension. What they have done, it's a multi-institutional, multinational study in which they took patients from last 5 years, from 2020 to 2025, of all patients who were entered in the electronic data as having intracranial hypertension. So there were overall 135,000 patients. And among these patients, they isolated those who had venous sinus stenting or VP shunts. And what they looked at was the effect of these procedures on the symptomatology, on the recurrence rates, the admissions, the emergency visits to the ER, and the probability of having drug-free possibilities. So I'll just have a comparison here. 90%, they were like total 101,362 patients with stenting, around 5,000 patients with CSF shunting. 90% were females, And interestingly, 41% they were overweight, 46% had visual disturbances, and around 21% in the stenting group had pulsatile tinnitus, and 46% in the stenting group had papilledema. So, what were the outcomes? The treatment failure rate for CSF shunting was 38.6%. So, and in 9.6% there was treatment failure. So, if you can compare, and the emergency department visits and inpatient admissions were 40% up to 35 to 40% in CSF shunting as compared to 22 to 24% in stenting patients. The medication use, they're more or less the same. And as far as the effectiveness of the symptoms are concerned, they were also same. So the basic difference that we have now is that the failure rate of VP shunt is at least 4 times more than as compared to sinus stenting. And if we take out the cost, in the same article it was written that the cost of revision, readmission, and emergency visits exceeds 5 times the cost of venous sinus stenting. So how it is done, obviously, I'll explain this in detail, but we usually have dual access from the femoral artery as well as from the femoral vein. We do a basic angiogram through the internal carotid artery. We localize the stenosis, measure the diameter of the stenosis as well as the gradient across the stenosis, and then we pass the stent across it. So this is a case of a 20-year-old female which we recently managed. She is a doctor by profession and doing her house job right now. During her medical school years, she started having headaches and visual disturbances. She is normal weight, and then she also had tinnitus bilateral, more on the right as compared to left. She also, obviously, she had medical management. She failed. She underwent lumboparatolin shunt, which after the shunt, she developed CSF hypotension and tonsillar herniation. So it had to be removed. And then with all these symptoms, she came to us. So what we did, that we did MRV. Interestingly, she never had an MRV done before. And once we did an MRV, she had bilateral transverse sigmoid sinus stenosis, which was more on the right as compared to left. We did cerebral venography, and we did intrasinus manometry, which gave us a gradient of 17 millimeter of mercury. And we passed the stent. Immediately after stenting, the tinnitus improved. Her headaches improved over the next 2 weeks, and papilledema resolved slowly over the next few months. So once we do an angiogram, this is the lateral view, this is the AP view, this is the superior sagittal sinus, this is the transverse sinus, sigmoid sinus, and internal jugular vein. Similarly, this is the superior sagittal sinus confluence, right transverse sigmoid junction, internal jugular vein, left transverse sigmoid junction. As you can see, there is bilateral stenosis of transverse sigmoid junction. Right is dominant, left is hypoplastic. And interestingly, in this patient as well, the MRV was reported normal. So then what we did, this is how we measure the intrasinus pressure. This is the distal part of the catheter, which I am pulling back, and it is now crossing the stenosis. This is the distal part. This is distal to the stenosis. This part is proximal to the stenosis. So what we do is that once we have intravenous access, we go to up to the internal jugular vein, from there into the transverse sigmoid, and then into superior sagittal sinus. We start measuring the pressure from the superior sagittal sinus. How we measure is that we attach the hub of the microcatheter with the pressure transducer, and which gives us the live measurement, live intrasinus pressure. So I'll play this now. This was the pressure measurement distal to the stenosis. And once we cross proximally, the pressure suddenly dropped to 20. So it's a significant gradient. For a gradient to be significant, it has to be more than 4. In this case, the gradient was 17. So this is the process of passing the stent. This is the stent which we are trying to cross. It's a bit fast forward. So usually it's difficult to cross this angle. And then once we reach the distal part, once we cross the stenosis, we unsheath, and the moment we unsheath, it's a self-expanding stent. It conforms to the anatomy and the diameter of the vessel. Obviously, we do the measurements. So as we unsheath the stent expands and also expands the stenotic portion of the sinus. But if for some reason post-stenting there is not good opening of the stent, we can do an angioplasty afterwards as well. So this is the image post-stenting. As you can see, there was initial stenosis of the transverse sigmoid junction, which no longer is seen, and the flow on the left transverse sinus is also reduced. So as far as safety is concerned, so overall major complication rates are less than 2%. What we have, there was one patient in which there was stent thrombosis. These patients are usually loaded with dual antiplatelets, and we do not do platelet inhibition test because we're using ticagrelor, and there isn't any resistance which has been documented to ticagrelor. And other than that, we can have subarachnoid hemorrhages, you can have subdural hemorrhages or cortical venous hemorrhages, but we haven't had any patient with any complications so far, except for one which developed thrombosis, and we managed that thrombosis with the help of intravenous tirofiban. You can have access site complications like any procedure that we do. Stent migration deformation, we haven't seen yet. And long term, obviously, we don't have our own data, but as far as the studies are concerned, 5 to 10% of the patient can develop restenosis, either the place where initially stent was passed or some other place, and we can have the resurgence of symptoms, and the patient can be treated with a restenting. So I will conclude by saying that venous stenting is safe, is effective, and it's a durable treatment for selected patients with medical refractory idiopathic ventricular hypertension, especially those who are associated with venous sinus stenosis. It targets the underlying pathophysiology and etiology which is causing, unlike other procedures which are just mitigating the effect of increased ventricular pressure. So all patients in which they are going VP shunts and ending up with re-VP shunt in more than 50% of the cases, and we need to identify these young females and send them for venous sinus stenting, because this up to date, it has shown the studies that it is more safer, durable, and is more effective as compared to other shunting procedures. Thank you.